Let's talk some additional EKG views and EKG leads. We're going to talk about two additional EKG lead placements outside our normal 12 lead, and one is the posterior lead placement. That's V7 through V10. So if we see ST segment depression in V1 through V3, we know those are reciprocal to our posterior leads. Our septal leads are reciprocal to our posterior leads. So if we see ST segment depression in our septal leads, we're automatically going to do a posterior EKG in this V7 through V10. We'll talk about that. And then also our right side leads, V4R, V5R, V6R. So if we see an inferior infarct, if we see ST segment elevation in our inferior leads, lead 2, 3 AVF, it may probably include the right ventricle. So we're going to look at the right ventricle. So looking at V4R, V5R, V6R looks at the right ventricle. All in combination, our right-sided leads are V4R, V5R, V6R. Look around the side of the right ventricle. Our posterior leads, V7 through V10, look around the posterior side of our left ventricle. To place our right-sided leads, we've got V4R, V5R, and V6R. So we just place them in the same anatomic position that we did V4, V5, V6. We just switch those over to our right side, and we are physically putting those leads onto the right side. And when you print these out, we only have, so many cables. When you print these out, please kind of label them as V4R, V5R, V6R, because your computer is not going to know. But we do know that we switch them over, these lead placements, these cables, over to the right side, but same exact anatomic position as V4, V5, V6, just on the right side. Our inferior wall MIs, you see ST segment elevation in lead 2, 3 AVF. Most of these occur in conjunction with some right ventricular involvement. So usually the right coronary artery, sometimes left circumflex, but usually right coronary artery. So anytime you see an inferior wall MI, anytime you see ST segment elevation in 2-3 AVF, your inferior region, automatically do a right-sided 12 lead. So I've got this patient here. I'm doing my 12 lead, lead 1, depressed. ST segment depression, I should say. Lead 2, elevated. Lead 3, elevated. AVL, depressed. AVF, elevated. V1, a little elevated. V2, normal. V3, a little elevated. V4, maybe a millimeter of elevation. V5, V6, normal. But I see this elevation 2-3 AVF. I've got reciprocal changes in 1 and AVL. V6 might have a little teeny tiny bit of SC segment depression. That's arguable, but excuse me, 1 and AVL definitely depressed. I've got elevation 2-3 AVF. I'm going to do a right-sided 12 lead. I've got V4R up here, and that is elevated. ST segment elevation in any of your right-sided leads tell you that you have right ventricular involvement. This EKG here only shows V4R, but please do V4R, V5R, and V6R. When it spits out your printer, scribble them out and rewrite the right-sided leads in there so you just don't forget and it gets jumbled in with all your other 12 leads. So why do that? If we just do that one V4R, and you're going to see this a lot. You're going to see this a lot in the field where someone might do a right-sided 12 lead and they just move V4 over to the right side. Well, are we gambling on that one singular window catching that right ventricular infarction? Well, no, we can move all three windows. Let's put more windows on that right ventricle. Let's do V4R, V5R, and V6R. So just don't do one, do all three, and get a good view of that right ventricle. Moving on from our right-sided views, we also have these posterior views. So we can continue on our electrodes around the backside of the heart, the backside of the body anatomically. So here we're continuing into V7, V8, V9, even into V10. So moving along the mid-scapular line, the vertebral line, still along the fifth intercostal space. And we're moving these along. Again, we only have so many cables, so when it spits out of your printer, please relabel these with your pen, just so you know exactly which leads you're looking at, which posterior leads you're looking at. So here we're looking at this posterior view, the posterior portion of the left ventricle. And hopefully you're doing this normally, if you've got time to do it in this posterior view, but anytime you see ST segment depression in V1 and V2, automatically do a posterior wall 12 lead. If you see depression in V1, V2, that is an automatic decision point right there. I should be doing a V7, V8, V9, V10 view to look at the posterior side. Hopefully you're doing this on every patient. Sometimes there are time constraints, but hopefully you're doing it at every patient. But at the very least, if you see depression, ST segment depression V1, V2 in your septal, your reciprocal leads are to your septal leads are your posterior leads. So pop those on real quick. It's just a few more stickers. Takes you an extra like 21 seconds and get a posterior 12 lead. Here we're seeing ST segment depression in our septal leads, V1, V2. I know that the reciprocal leads to my septal leads are my posterior leads. So I'm going to flip over and take my normal V4, 5, and 6. Move those cables around the back side of the heart, again following the fifth intercostal space, around the back side of the body of the heart, of the left ventricle. Look at V7, V8, V9. We're going to have to write these in ourselves. Your computer's not going to do that for you. So please write those in as they print out. And so I've got ST segment elevation here, V1, V2. And lo and behold, I've got ST segment elevation, 7, 8, 9. I've got a posterior wall MI.